Hi, Justin.
Good morning, Justin.
Hi, everybody. Saudi Club. Good to see you.
Great to see you.
Likewise.
Good morning, Ferris.
Morning. Morning, Dr. Sikura. Good morning, Justin.
Ferris is Dr. Vanapa here.
Oh, okay. Let me call Dr. Wanapa.
Thank you all for your good work with Cambodia. Sounds like things are getting better there.
It still have some annoying incident in the border.
Oh, no.
Some patrol, some patrol conflict.
Okay. I hope those settle down.
Hi, everyone.
Hello.
Hello, Wanapa.
Good morning.
Good morning.
Hi, we have a few presentation this morning. Give me, Ajahn Amon, are you ready to be up? Present
Yep.
short? Yeah.
My topic today, we are talking about the update of our shock center. Can you see my slide?
We can see them,
Yes.
yes.
Okay, so this is a quick presentation. So let me show. Okay, so I went to Oslo last year, and since then we do a lot of progress in many fields. Okay, so since then since January we had conference we call Shock and Heart Failure Conference. We have a staff from Phayyathai, Phahon Yotin, Phayyathai 2, and our some of the university staff who have the expert in heart failure and shock field come to join us. We have a few case discussion. We have a few interesting case about post-operative vasopressia and complex tissue issue in heart failure. And then we still waiting for our hemosphere. We think we can get our hand on this year, but we have a chance to try this new monitor in some patients. And we have the basic ECMO setup and troubleshooting for our staff because our nurse has been trained on the basic cath lab procedure. Doing the ECMO is a new thing for them. So we have a couple of sessions that we bring the technician from the company and try to let them get their hand on. And in 2025, we do a lot more right heart catheterization. During the first 8 months, we have about 40 cases that we do the right heart cath to evaluate fluid status and calcify pulmonary hypertension and many other reasons that we would like to do the right heart catheter. And we do more using Swan-Ganz catheter in the cath lab. Last year, in 2024, we used about we have 8 cases, but in this year we use about 10 cases in 8 months in the cath lab. And we have 3 cases that we monitor the Swan-Ganz catheter during the CHIPS procedure. And we develop our own system to automate hemodynamic calculation using the table and formula. So once we get the data from the hemodynamic monitor. Our nurse put the data in the spreadsheet, and they calculate everything for us. So, and we can keep tracking all the data that we have. And this is an example case of the value of Swan-Ganz catheter. We have a very old patient, 92 years old, heart failure, very poor LV function, and have the double valve tower, and we have to do left main intervention that is very complex. Without having the PA catheter, it's very tough to perform the procedure like this, because we don't know when the patient will collapse. So that the PA catheter give us a confidence to progress to the procedure. And 2 weeks ago, we have a chance to have the simulation for ultrasound guide puncture. We made a gelatin model, and we have our many doctors come to join us to try the hand on the model. This event actually happened at BDMS. I have a chance to join this meeting. And last week, we have the first ECMO case in our CAD lab. Actually, this is a young couple that come at the same time. They are in mid 20 years old, and they collapse at the same time. We think they have some kind of the toxic exposure and develop cardiogenic shock that we have to do CPR and start doing the ECMO. I know this is not an ideal situation to start the ECMO program, but because they are very young, around 20 years old. And summary of the activity that we did in our center, we have about 40 cases of right heart cath. We have 10 PA catheter insertion in the cath lab, 3 chip PCI. We have 2 shock conference with our staff from university, and we have 2 basic ECMO drills for cath lab nurses. We have simulation how to use the new device like ultrasound guide puncture, Percoros Manta device, and we have a chance to do real ECMO CPR cases last month. Okay, thank you. This is our update.
Thank you. Any comment from you, Prof. Figueroa?
Absolutely. So, what wonderful progress in a systematic way. And I think that the theme here is, from the beginning, the use of and training of how to get vascular access using a vascular safety bundle, incorporating not only using IVUS, but using ultrasound, but understanding how to employ the ultrasound to get at the right stick site and make the insertion of the large bore sheaths safe, while also making it safe to attain hemostasis, with closure devices, and understanding the merits and challenges of Perclose versus the Manta device. And so those are the fundamental blocking tools that you need, and introducing that and creating awareness and standards amongst the team is really, really important. The second is a consistency about implementing a systematic approach to the use of invasive hemodynamics, and then secondarily creating the visuals with which to go to the important components that include, SVR, PVR, PAPI, and cardiac power, where cardiac power remains the most important predictor. So it's not only putting the line in, but it's presenting the data that allows the analysis by the physician and team to make the appropriate decisions to help support that patient. And then, ECMO is not for the faint of heart. And so it's preparation, before, during, and after the ECMO cannulation, and all of the associated expertise to do that. So I'm really proud of how you have led the team to implement a very thoughtful and disciplined approach to patients at risk or with shock. And I think that the journey the next 12 months is only going to grow in impact. And I just want to remind everybody, as I said, shock is not for the faint of heart, because a moderate number of these patients will not survive, and that's hard for the team. And a moderate number of them, despite the best tools and the best judgment, will have complications. And having a place to surface and discuss outcomes and the associated stress it has on the team when things don't go well is an important part of this journey. Thank you.
Thank you, Prof. อาจารย์นรัตน์คะ any advice from you?
That's excellent performance, and perhaps later we can share your program for the hemodynamics input data. Then the other side can copy or learn something from you in details for the data. That's excellent.
Thank you ค่ะ Anyone else have a comment before we move to the next presentation? We have time. If not, let's move to the action plan of PTP, please. Oh, I saw some hand raising. Whose hand is that?
Clapping.
Oh, okay.
Clapping, Wanapon. I just want to say how happy I am. This was a great presentation to start with. And one of the reasons that I love working with your team is the engagement and the changes that people wind up implementing. And it's why this relationship is so important and fulfilling for me.
Thank you, Prof. And you are the great teacher as well. So we cannot forget that. Next thing is, please. Are you ready?
Ready ค่ะอาจารย์
Please start. Thank you. We don't see your slide yet. Slide มันหาย
ค่ะ please a moment please
เพราะทีมปิดนะคะ You can see it, but please make it full screen.
full screen อ่ะ ให้พี่สีชี้ได้ไหม share desktop ได้เลย
Okay ค่ะ it's full
โอเค
screen
นะ
now
คะ
please
สวัสดีค่ะGood morning and good evening นะคะ everyone นะคะ My name is เอื้องดอยเฉบแหลมนะคะ I am a nurse manager from พญาไทพหลโยธิน Hospital ค่ะ Today I would like to present our action plan. Okay. We have agenda นะคะ First, summary for performance 2025 and second action plan 2026 ค่ะ Action plan 20 Action Plan 2025 First, increase contact network hospital and company. Second, knowledge sharing with referral network hospital and company. And third, improve process and clinical outcome. And the last action plan initiative, set up arrhythmia center. In the first initiative, increase contact network hospital and companies. In 2024, there was a hospital that referred a case to us for treatment. However, in 2025, the hospital opened its own cath lab. This caused nearly 50% of our case to decline. To address this, we sought additional contact hospital to resource enough case volume. We have entered into new contact with 2 hospitals that serve social security patients, and a cardiologist is scheduled to provide our patient service once a week. พญาไทพหลโยธิน Hospital operate 17 company clinic. We create a line official for employee to directly contact the hospital in case of emergency. Line OA includes a fast tag menu that link directly to the emergency hotline. We start East SCB company and it has already been implemented. One patient. We also provide a heart risk screening menu where employee can access their knowledge of heart disease if any abnormality are detected. A nurse will contact them to provide advice on further check-up and treatment. The next action plan, knowledge sharing with referral network hospital company. Initiative. Every month, our cardiologists and team visit contact hospital and corporate partner to provide health education and share patient care practice, giving employees the chance for direct consultation with the doctor. Action plan third action plan, improve clinic process and clinical outcome. Activity 1, disease loud as criteria, we have achieved only 25% compared to 10% last year. Key point we have identified is the finance. It was agreed that our hospital would accept patients under all type of coverage, providing patient safety. activity about heart team conference in case criteria achieve 100%. Activity third, improve time of first medical contact to first device activation for STEMI case. Percent achieve target in referral case. Last year show that one hospital which is among the top inpatient referral failed to meet the KPI. Root cause analysis. The issue identified were delay diagnosis, insufficiency in managing the transfer process in first hospital. We implement guideline and Ticker 2 acute coronary syndrome, conference case and cardio consult 24 hours. After implemented the activity, the results of the hospital we focus on have improved in year 2025, but are still not satisfactory, and some hospitals still need focus and further corrective action. The fourth initiative set up arrhythmia center. In the past year, we were unable to perform catheter ablation in AF case. Dr. Tuan Thosapon arranged for a physician with professor level expertise to provide support. This has enabled patients under the Social Security scheme to receive treatment at our hospital without bearing a cost. And this competency nurse simulation cardiac arrhythmia. Nurse staff participate 100% and pass evaluation 100%. This slide shows statistics of each type of cardiac intervention procedure. The number one is CAG PCI, and the second is EP, and the third is open heart catheter-line heart. Agenda. The next agenda is Action Plan 2026. We have 4 initiatives. First, minimal invasive surgery, and second, arrhythmia center by Magnet Doctor, and third, aortic excellence COE Twilight, and fourth, hybrid shape cardio VAD and valve. Thank you.
Thank you, Ka. Prof, any suggestion for PCP?
So, congratulations on a very thoughtful approach. Just a couple of comments. I think that engaging the partner hospitals and community and being visible and making ease of communication and access is really essential. It goes to being affable and available and present. And I think those are key initiatives. So they think about you and your team as part of the community and part of the solutions that makes it easy to improve the care. The second thing I would say is, in looking at the door-to-door to balloon times, I would suggest for the LPH hospital, where you had an improvement from 40 to 57%, to continue a rapid action team to focus on each patient, identify and implement changes for the next patient, so that that number can drive up into the 75 to 80% probability, because every 15-minute delay increases the risk of mortality is the American Heart Association. So for that particular area, I would have a special team really continuing the dialogue and the focus on the barriers and the opportunities to continue to drive the improved outcome. The third comment I would say falls under your coronary angiography and PCI, and you're to be congratulated for, in essence, hitting 90% radial. It reduces complications, reduces costs, patients are happier. And that's been a big drive that we have set out to do, and you all have accomplished that. And so that's been a lot of work to get various operators and the cath lab team to be radial first and to do that well. And I'm very proud of you. In the PCI, the volumes now are quite nice. I think I saw 300 PCI. And I don't know how many of those are ACS, but I would add in your goals for this upcoming year to take the intracoronary imaging, which I think was less than 5, and it should be present for at least every ACS or every complex stable ischemic heart disease. So that threshold, based on the evolution of the data and guidelines, should now become a default for all ACS and should frequently be used for all stable ischemic heart disease. And given the change in the guidelines, I would put that into a goal for this upcoming year. And I think, no doubt, just like you all did for radial, you'll be able to do the same for intracoronary imaging. And I think that, as Dr. Damras always states, it's not just about doing the imaging, it's about learning how to interpret the imaging and how that imaging changes your lesion preparation. And if you do that well, you reduce restenosis and future infarcts. And so that's become a big, important area. And I would add that to your goals for this upcoming year in your PCI goal. That would be number 1 for me.
Thank you. Thank you.
Thank you, Prof. อาจารย์นำรัตน์คะ Any advice for PTP?
Yes, I'm so proud that when Paulo Ponyotin joined COE under leadership by Dr. Tuan Tosapon, I remember the first day when I visit Paulo Ponyotin I said ground zero, from nothing, and then you build up so smart of the audio context. Congratulations, and of course, Dr. Tuan Tosapon is the leadership of the Payatai Group, and I hope that you are going and doing much better. Yeah, because you have a lot of network that have to improve, and it's difficult for the metropolitan area compared to the other regions where it is just a focal local networks. But in Bangkok, it's a good thing. Congratulations again, from ground zero to this level. It's amazing.
Agreed.
Thank you. Thank you.
Okay, hope you have had happy encouragement and you can do even more for PTP in the future. The next one is Ajahn Namrat himself. You have plenty of time, Ajahn, half an hour.
Dr. Damras, I want to guess the title of your presentation. What movie will it use for the phrase?
Ajahn Namrat, any movie of title?
No movie. this session has no movies. But there will be a Beauty and the Beast on November. Okay, I would like to share with you our first BDMS and Center of Excellence the training, the shock simulation on the 5th and 6th August this month. So we have a 1.5 day session. The first day, there will be a 2 lecture by Dr. Michael Lee from Queen Elizabeth Hospital in Hong Kong. He talked on the latest HACC guideline and recommendation for MCS in patients with acute cold syndrome and cardiac shock, and the clinical outcome review and what we have learned from NCSI and DanGer. And we have a group discussion to share the case, the high-risk shock case by Dr. Michael Lee. And then followed by my talks on the right heart the catheterization setup and interpretation. And I urge all the hospital under BDMS to focus on right heart cath and hemodynamics before we get the true impeller. And after that, we have 4 workshops. And this workshop, we have in total 24 participants and 14 doctors, 5 interventionists, 4 surgeons, and also intensivists and general cardiologists. So we have a 4 station. Station number 1 is impeller setup and insertion, suture, and dressing, arranged by a Biomed company. Station 2, troubleshooting in ICU patient check-in. Station number 3, access management closure device. We have 3 different closure devices to show and hands-on on the model. And station number 4, ultrasound guided arterial puncture. And I would like to congratulate Dr. Amon for his the excellent hard work to make a gelatin box and also apply with the ultrasound for us to try to do the puncture into the gelatin box into the vessel. And we have and at the end of the day, Q&A brief. We have separated into 4 groups, and each group rotate at 45 minutes from station 1 to 2, 3, and 4. From these 4 groups. So each group has in total of 6 number of participants. And we learn a lot. I mean, this is quite interesting for simulation. So our first simulation program, 2 lecture, as I mentioned, overview critical update for shock management. And what we learned from Hong Kong and that we should copy this thing is the situation of impeller reimbursement in Hong Kong. We know that the lobbyists are very important to bring impeller to life. I mean, the financial constraint is one thing. And if we have a lobbyist, that I'm the one who did in the past when I still work in the university hospital. I was the lobbyist for our 3 program of reimbursement and try to improve the outcome by accommodate all the devices, important devices. So what we learned from Hong Kong is the number of impeller improved because of the total reimbursement for AMI-CS. And now they are going to the chip PCI CS also. And right heart catheterization is mandatory before everything, while we are waiting for budget request for a Biomed console and impeller catheters. That I guess maybe 2026, that BHT would be the first hospital to start with this program. For simulation room is fully packed of non-invasive monitoring, invasive monitoring by using a Hemosphere, hands-on impeller preparation, as I mentioned, insertion and off impeller, how to off the impeller and do the suturing. Biomed controls observation, ultrasound guided femoral puncture, Swan-Ganz catheterization insertion in a model with observation on monitors for pressure change. And we teach them how to do the zero level setup at the mid fourth intercostal space, mid chest, zero level. And also IBP pressure observation for optimal IB support. Let's say like systolic unload, and also the V shape of the diastolic augmented blood pressure. And the most important thing that we try hands-on on the Crucial system, ProStar, Manta, AngioSeal, etc. on this model. And thank for the company who joined us. And second day, we have a case-based simulation run by Dr. Vichai and Mr. Aditat to share the true case and briefing and ask all the participants for the decision making based on the changing of hemodynamics. We changed the hemodynamics from time to time and ask them what shall we do next. So the case was a non-SC elevated ACS, high grade score, urgent angiogram, LVDP was 35. Initially, systolic blood pressure was over 120. And after each engagement of the catheter, patient got a VT every time and need the shock to convert VT. And then deterioration of hemodynamics and turn to SCAI shock stage B. And we asked all the participants, and everyone agree that we have to put on impeller. So that is one good side. And then second side, because we don't have impeller, the group discussed that without impeller, we have to insert IBP first to see how we can stabilize the hemodynamic. That was the case-based simulation. And this consensus of the group stop the procedure, group agree upon IBP. Impeller is not available. Heart team approach. We have 4 cardiac surgeons in the case simulation, and all the surgeons they are discuss about the shock B, shock C. How can they operate? And most of them decline for the surgery and agree to go on with balloon pump or impeller. And right heart cath before transfer to CCU monitor everything. And we use the Hemosphere hemodynamics from the company and try to change the cardiac output, CI, CPO, PAPI, etc. and ask them, what shall we do next? What shall we do next? And what shall we do next? And guided fluid, NOE, and learn the PADP and mean pulmonary capillary wedge pressure in ICU to guide all the management. So these are what the company show us, the consumable technology supported, both non-invasive, ClearSight, finger cuff, Foresight, Elite, minimal invasive, Acumen IQ sensor, FlowTrack sensor, and four line Swan-Ganz catheter with the thermistor. We don't need to do the saline to measure the thermal dilution cardiac output. This is automate immediately. And we are very happy that we learned that 3 centers under BDMS has agreed to purchase their budget on this technology from the company. So 3 of 15 agree to have the machine. And this is the Hemosphere monitor offer full range cup sensors, catheter compatibility, and we learn how to use it. I mean, some doctors, some intensivists, they have experience with this the Hemosphere, and some other were among the first to observe the powerful Hemosphere the application to help us and guide us how to manage. So this is the portable machine, and we change all the parameters and ask what shall we do next. And this is again the SVR, etc. Everything that we learned from this the Hemosphere application, and we use this shock management from advanced parameter type of shock, 4 type of shock: MAP, cardiac output, DO2, CVP, MPAP, wedge pressure, SVR, and also this kind of treatment. So we use this for the simulation case. And these are all the Hemosphere monitoring during the simulation. Some may follow through, some may confuse, but we hope that day by day, when we got the machine and we have to learn it and know how to use it properly for the true shock case that are coming. And of course, we have to wait ABioMed console and also Impella. So this is the environment during the lecture. This is on the shock simulation room. You see that we have 6 or 7 observers try to answer what we put on the screen of what is going on. The case has been arranged by Dr. Vichai and Mr. Aritat. Thank you for both of them. And these are the cardiac surgeon who stand here and answer that shall we do interventionist, general cardiologist, intensivist. So these are how we do. And this is a Swan cancer model. So we ask each one of them try to insert the Swan cans and look at the pressure tracing and where are we by looking at the marker on the Swan cans catheter each 10 centimeters. 10 centimeters should arrive right atrial, and then right ventricle, and then pulmonary artery, and then PA wedge. These are the again what we discuss a lot. This is the interventionist from Bangkok Pattaya. This from Hat Yai. This from Phuket. So everyone learn and share, and I guess they are happy for this simulation. This look how they respond. The action, you can see that is funny. And these Swan cancer non-invasive room simulation. These are the Dr. Michael Lee. This Dr. Vichai tried to use the Perclose ProStar. Dr. Amon, Dr. Vichai, Dr. Permyot, looking at the gelatin model that Amon tried to guide them to perform the ultrasound guided. This is all the members that participate on this simulation program. This our surgeon also tried to do the arterial puncture through the gelatin model also. Interesting. And these are Swan cancer, as I mentioned, how to do the 0 level to make sure that we have a good 0 level calibration for hemodynamics. That is very important because sometimes patients could lie flat. Sometimes patients need a 30-degree or 45-degree heads up. So we have to make sure that all the data is a true and valid data for us to interpret and follow treatment. And this again, this is the beautiful doctors, general cardiologists, who are the first one to volunteer to answer for the case, to look at the patients, the model, the patient's the patient symptoms, and ask another one, what shall we do next? She's action. She has a lot of action on her activities as every one of them. So I thank you for SIM teams, speakers, company preparation, ABioMed, and delegates who sacrificed their precious time to be with us. And of course, also Dr. Sigaro and team who inspire us for shock management in this 2025. Thank you very much. I've stopped my sharing now, and I would like to hear your comment.
Thank you, Prof. Damrat. Prof. Figueroa, please.
So what an outstanding engagement by the team. And I only wish I was there to learn with you all during this 2-day conference. And, I love each of the critical steps in the decision making and the focus on insertion and interpretation of the response of the patient to the therapy. And, in too many instances, people think that you put the device in and you're done. But I think the approach that you all have taken with the education and the evaluation of patients pre-lab, lab, and post-lab indicates that you all have a outstanding understanding that the insertion is just the beginning, and all of the comprehensive data and how you present it to lead to actionable items by the team, which extends well beyond the proceduralist. And I love the way you all organized it, executed it, and the areas of focus. I just wish I could have been there to learn with you all.
I promise to the team that we will arrange this simulation twice a year. And of course, whenever we have Impella, the real Impella, and also if we have the case, of course, we will invite you to participate with us and learn from the real case. I focus, the first case should be on the chip PCI case and not waiting for the MICS. But for the chip
Yes.
case, like you perform, like you lecture us the last meeting of your DK crush with the LV of 20%. That was very, very excellent the teaching case. And I promise to you that we will have a new 2 devices that I hope that we can share with you in November. We call the dedicated bifurcation stem. The first, the BioSlim for the main branch bifurcation. And second one, very interesting, it is an Indian company we call Biomam branch. It has been indicated to use for the osteocyte branch. Let's say like osteo circumflex, 001 Medina. That is a pain point for all interventionists. And if we have tried that device, and if we can share with you, link, share, learn, and integrate to our chip case, I hope that we get the Thai FDA approval and we start to use the case. And we will have a Biomed IVL approved by Thai FDA now, and we can learn a lot more from you on IVL and in the next coming meetings. This is the thing that I promised, but we have to discuss about budget. And I have a agenda to see the CEO group this 3:30 in Bangkok time to discuss with the budget, because this year I think there is a lot of budget constraint. Everyone has to tighten their belt because of the Thai-Cambodia the border conflicts and etc. A lot of Cambodian patients are not coming, and also because of some are not traveling to Thailand, they go somewhere else. So this is the thing that we have to try to clear. And I hope that in November we have a very good session, good things, and I will send you my agenda for both of you, for which the topics that I want Dr. Sikura and Dr. Firas to cover, and also from our side, which hospital will provide their case sharing or mini lecture or whatever. That will be the focus on this 2 months time. This is near the end of August. Then we have September, October, and then November we see each other in Thailand.
That's about 10 or 11 weeks from now. So it will be upon us, and we're very excited to be present with you all and to learn, contribute, and to spend time with friends.
Thank you, Prof. I think we finished everything, so we can farewell to each other for now.
Wonderful. Well, thank you so much. 3 wonderful presentations, learned a lot, and remarkable progress since last November.
Could everyone open your camera? Then we can see each other before we the meeting will be adjourned. Please open your camera. Not everyone.
Thank you,
So I
everybody.
would
Have a
like to take
beautiful
the
day.
picture on the screen.
Very kind of you.
Okay, thank you very much. Now,
Bye-bye.
Dr. Vanapa, it's your time to say goodbye.
Bye, Wanapa.
Goodbye, all. Good
Bye.
presentations. Thank you. Very interesting work.
Mm.
Congratulations.
Okay,
Thank you
bye-bye,
to Justin
everyone.
and Dr. Sekiroga.